Hey everybody, welcome back to the podcast. We are doing a special series on COVID-19 and the impacts that it will have on both the healthcare and economic space. And today I'm very lucky to be with Dr. Sujit Vasudevan, who's a family physician and practices in Cochin, Kerala, who are doing very well at containing the virus right now. And he's been practicing for about 41 years, so he has great experience. Hi, Dr. Sujit, how are you doing?
Hi Arman, I'm fine, and how are you?
Doing good, doing good. And I really want to, jump into this topic because it's very important that we fight against the spread of misinformation right now because there's a lot going on. We're getting WhatsApp messages here and there saying this about the virus, saying that about the virus, but a lot of us don't have a clear understanding of what it is really. So could you go into what is COVID-19? How did it start? How do I get it? And how does it spread?
Okay, I agree with you that there's a lot of misinformation or fake news about COVID. I think there's some kind of a machinery going on which manufactures fake news all the time. Now to expand COVID-19, that is coronavirus disease, and it was discovered towards the end of 2019. So the 19 comes in. That's the expansion of the acronym COVID-19. This is a viral disease. Viruses are small submicroscopic particles. They are not alive according to all studies, but they can cause a lot of havoc. They've been around for some time. And the word virus actually comes from a Latin term meaning poison. So this two terms may be very familiar to most of you. One is called SARS,
Mm-hmm.
SARS, and the other one is MERS, MERS. And the third one, which is extremely common, which everybody understands, is common cold. Now, all these diseases were caused or are caused by a single virus called as a coronavirus. Only thing is that they are mutated different forms of the coronavirus. Why it is called corona is because when you look at the microscopic or atomic microscopic picture of the virus, there are certain spikes which are protein spikes which resemble the corona of the sun. So that's why it's called coronavirus. Uh, the disease of COVID-19 is caused by what is now categorized as SARS-CoV-2. That stands for the Severe Acute Respiratory Syndrome Coronavirus 2. It's self-explanatory. The severe acute respiratory syndrome is the symptoms which are caused by the disease, and coronavirus 2 because if you understand, a few decades ago there was another epidemic which originated from South China, which was called as SARS, and now that is being referred to as SARS-1, and this is SARS-2 or SARS-CoV-2. This appeared, for all practical purposes of what we know, in late 2019 in a city called Wuhan. It's a huge city in southern China or south central China, and it may have originated in a wet market or a seafood market in Wuhan, and it is a zoonosis in the sense that this virus is normally found in animals and it transmitted between animals, but sometimes it mutates and jumps species. So it jumps from animals to human beings. And in this case, while there were a lot of initial thoughts that it could have come from civet cats or from pangolins or from snakes, it is now more or less established that it has come from fruit bats, which are very high, I understand, on the menu of the tables in China. So this is zoonosis, is jumped from bats to, or possibly from bats to human beings, and they cause respiratory symptoms in human beings, just like MERS or Middle East Respiratory Syndrome. And the Method of spread is by what is called as droplets, or it's an airborne infection. But this being a slightly large virus doesn't, hang around in the air for a very long time. It travels a distance of about 1 meter or 1.5 meters and then settles down. So it can come either if somebody with the disease coughs in your face or sneezes in your face, or you touch the secretions which are on surfaces and then touch your own face or mouth or nose, or it can even enter through the eye. So this is the way it is transmitted, and these are the basics about the virus and where it originated from. I hope that that was simple enough for most people to understand.
Yeah, I think it definitely was. And so the way it mutated from animals to people, you're saying, in theory,
Yeah.
is because we would have eaten said animal that is linked to this
Or come in
disease, to this virus.
not necessarily
Okay.
eaten, even coming in close contact.
Okay.
Coming in close contact when you tend even eating,
Mm-hmm.
because there are many civilizations or many types of ethnicities which do not cook their food adequately. So even buying a piece of meat which is contaminated and taking it with you could cause the infection. But I read an article yesterday on from a fairly reliable source that the zero case, as we call, or the index case, the first case was a shrimp seller in the Wuhan seafood market, and she could have
Mm-hmm.
got it from somebody from a common bathroom in the market, in the toilet. Yeah, so that's
Mm.
because they the if you look at pictures which have been disgustingly filling our telephone and other screens,
Mm-hmm.
you would
Mm-hmm.
have seen the animals in cages or dead animals being displayed as wares in all these markets. Things ranging from scorpions and cockroaches to snakes and civet cats and dogs and things like that. So
Correct.
it's a simple jump from an animal to. I mean, if you look at the previous ones, also SARS and MERS were from bats. Nipah was from bats.
Mm.
Swine flu was from pigs. Bird
Correct.
flu was from poultry. So these are all viruses which have mutated and learned to adapt inside human cells.
Mm. So
So it's
Dr.
not necessary that you
Sujit,
have to eat. Yes, sir.
right. So, Dr. Sujit, there's a lot of, again, information going about how again, you've gone into how we contract the disease, but there's a lot of information going around about how we can stay away from the disease. There's the mixture of social distancing, and then there is don't even go outside, don't even leave your house because there's a possibility, that, it'll somehow just fly into you. There's a lot of, crazy stuff going around. Now,
Yeah, yeah,
what are the actual strategies and methodologies
yeah,
that we can implement
yeah, yeah.
to ensure that we do not contract the disease?
Right. It's ridiculous to say that don't go out of the house at all because it's hanging out there. It's certainly not
Mm-hmm.
hanging out there. Like I said earlier, it's a fairly large viral particle, so it doesn't float around in the air for very long. So I think what we have been talking about for quite some time is about social distancing,
Mm-hmm.
physical social distancing. This is true of healthy people as well as suspected people, quarantined people, self isolated people. Everybody has to isolate it. The distance recommended is between 1 and 1.5 meters. I would say for safety, about 2 meters. Now, the lockdown was imperative uh, because, by nature and by upbringing, we are a very irresponsible race. I'm very sorry to say that. Maybe I should include myself inside that, but um, it's all or nothing for us. Uh,
Mm-hmm.
like, if the lockdown were not implemented, you would go out in groups. You would go to the park to have your walk along with a few thousand other people. You would go to the supermarket or your grocery store, or you would, go for a play or go for a movie theater. So I think while you cannot get it by just going out for a walk or going out onto the road, Certainly, if you come close to an individual who is harboring the virus, who is excreting the virus, if you come close to him, you are at great risk of getting the virus. So, similarly, if you are going, say, on an escalator or on a staircase, and you keep your hand on the railing, and the previous man who was, or maybe just 5 minutes earlier, or 1 hour earlier, or 2 hours earlier, if there's a metal surface on the railing, if the person has, infected his hands, his hands have come in touch with his saliva, and he has slid his hand down at the banister, down the railing, and then you put your hand on the railing and you go down, and then accidentally, it's estimated that everybody touches his or her face inadvertently about 400 to 500 times in an hour. Or is it a day? I forget. I'm not very sure. It's not a medical fact anyway, but you do that very often. So if by some chance you pick up this man's contaminated saliva or droplets or whatever is on your hand and you touch it onto your face, bingo, you got it. So you have to keep a distance, or what is called a social, physical distancing, and practice extreme. I stress this point of extreme hand and respiratory hygiene. When you say hand hygiene, it is washing your hands every time you think you have come in contact with some surface. Even if somebody delivers something to your house, once you have touched that container or you handed over some money to that man, because you've not been able to do online transactions, you thoroughly wash your hands with soap and water. If you do not have immediate access to soap and water, you use alcohol-based hand sanitizer and thoroughly wash your hands. Scrub your hands. That means, not just the palms and the back part of the hand, but in between the fingers, the thumb, the wrist, and the nails and the nail beds have to be thoroughly clean. You cannot overemphasize this. Because it doesn't take a very large viral load to infect you. Similarly, if you have got a cough and a cold, or you have any respiratory symptoms, it is advisable you wear a mask. A mask does not protect you surely from the disease. I don't think it's advisable or needed for everybody to wear a surgical mask. Surgical masks are worn, for example, if you have got a cold, which may or may not be COVID-19, and you need to go out to buy something urgently, or you need to go to the hospital because you're not well, please wear a mask and go, because you protect other people. Similarly, if you're in the house and you have a cold, wear a mask to wear your to protect your loved ones, to see that they don't come in contact with them. So I think that is the thing. But the lockdown is more of a disciplinary mechanism to get us used to the idea that isolation is important, that we should not go out in groups, we should not come in unnecessary contact with people. Man is a very social creature. I have been in lockdown, voluntary lockdown, much before the enforced lockdown, because I am over 65 years and I have diabetes. So I have locked myself up from about 12 days now. And there are times I feel very depressed. And then I realize it's for my own good. And unless it's really urgent, now I can get everything at my gate. I can get provisions, I can get vegetables, I can get chicken. The only regret is I can't get potato chips at my gate. That I regret. Yeah. So, but that's the idea of a lockdown. The prevention is by staying away from other people. That's the main prevention. And let me now put in a word, because there's a lot of talk about this chloroquine and hydroxychloroquine in WhatsApp, and doctors who should know better are recommending that everybody should take chloroquine. It's a very sad state of affairs, because this is not recommended anywhere in the world that everybody should take chloroquine. The Indian Council of Medical Research has said that there are two categories of people who should take hydroxychloroquine, as a preventive measure. That is healthcare workers who are directly working with COVID-19 patients and uh, caregivers and relatives of patients who are isolated at home who are proven to be COVID-19 positive. This is to protect them. Again, let me stress here that hydroxychloroquine is not an antiviral. At best, it protects the lung through a mechanism called as subsiding a cytokine storm or an inflammatory response. So what has happened now is that people are buying chloroquine and taking it. Chloroquine is a medicine not without side effects. It's got side effects, including side effects on the heart, on the eyes. And the second and very unfortunate thing is that people who are taking chloroquine on a regular basis for diseases like rheumatoid arthritis, seronegative arthritis, systemic lupus, and other diseases who take this on a regular basis, they are not able to get the medicine because people are hoarding chloroquine. So, whoever is listening to this, please talk to your doctor. I'm sure he'll be sensible enough to tell you whether you need to take it or not.
Dr. Sujit,
Yes,
thank you
Arman,
so much for bringing that up, because that's a huge point, and that's the huge reason why behind I want to do this series of podcasts, because not only hoarding of medication, like you said, that can potentially have more health impacts on the individual, but it is preventing those who need certain resources, whether it be medication, food, or any essential, from getting it, because people get into panic mode when all of this misinformation spreads.
That's human nature. It's human nature. I don't know, you can blame them, but it's our duty to educate them.
Exactly. That's why the proper information here, thank you for bringing that up. I want to dive a little bit deeper into social distancing, because like you said, before this lockdown, everybody was still going ahead doing their own things. Corporates were still open, and there was a lot of interactions. And there's studies that have come out. One posted by the World Economic Forum said that with normal behavior, one person will infect 2.5 people, which is 406 people over 30 days. And with 50% less contact, they will infect 1.25 people in 5 days, which is only 15 people in 30 days. And with extreme isolation, one person will affect 0.625 people, which is 2.5 people in a month. And if you think about in India, if you put that into India's perspective, we have a huge unhygienic, just due to education or resources, whatever it is, viruses can spread very fast in India, given our current state. So it is imperative. I definitely want to reinforce your point that social distancing is implied. We shouldn't be going to.
I have seen these figures. I think that they, these are all statistical projections, but they look good on paper, and I'm sure that it's what is in theory is fairly good in practice too, because many communities who fail to do this are paying the price now.
Exactly. And
India, can I interject for a minute? You said,
of course,
the chance of spread is high in India because of our overcrowding, our poor hygiene. I must add that our nutritional levels are nowhere near what they should be. Many people take carbohydrate-rich and protein-poor diets, which reduces the immunity a lot. The carbohydrates give you only calories or energy. They do not give you antibodies. They do not give you improvement in your immune systems. Nothing. So we are dealing with a population which is rather undernourished or poorly nourished. So in that way, it is the chance of spread is very high. But then many people are asking the question that, why are our numbers so relatively small? Is it underreporting? Or is it, if it is the truth, is there a reason behind it? And then there have been some studies, some glimmers of hope coming through that Indians genetically may contain a small genetic, uh, what shall I say, genetic addition in their systems, which may make them a little more resistant to the COVID than others. Of course, this doesn't give you a blanket permission to rush out in joy and kiss your neighbor, but uh, there could be one of the reasons why it's not going up. So while there are a lot of negative points uh, why this disease can spread like wildfire, there are little glimmers of hope coming through which may save our nation and race. From the bottom of our heart, I pray it's true, but it's early
Mm-hmm.
days yet. So I think in a couple of weeks we may have more news about this so-called protective mechanism in like there are some stages, some studies which suggest that malaria endemic places are less prone to get this disease. If you look at the map of the COVID spread today, you find a lot of Africa is not affected, and that's
Correct.
Africa, which is totally, you know, what is the word I'm using? Devastated by malaria, and these people seem to be a little prone to COVID. Is it the repeated malarial infection, which has given them some kind of immunity? Is it the overuse or misuse of chloroquine? We are yet to find out. Like I said earlier, it's early days yet. It's work in progress.
Mm.
Then this is not. This is just it's just some things coming in. I don't think that this could be classified as the gospel truth. It is just that there's some ray of sunshine amidst all this gloom. But I think the at the moment the gloom is good because it will keep us scared and quiet and careful.
Exactly. And we'll definitely keep, the listeners updated with that situation because hopefully, yeah, definitely, hopefully that's true. And I want to move on to the overburden and the potential huge overburden on our hospitals and our equipment in hospitals to deal with such a crisis. Now, I think it's fairly well known that we are underinvested in certain areas in healthcare, and we are under the recommended by huge amounts the
Yes,
number
yes,
of beds and nurses and doctors per population.
it is true. It's true. It's absolutely true. I think when we look at our system, uh, the system is divided into in India. Unfortunately or fortunately, we have several systems of medicines are running parallelly. Uh, you have what is wrongly referred to as allopathy, which I don't believe that word. It's modern medicine. We have homeopathy, we have Ayurveda, we have Unani, and we have a whole lot of other things like naturopathy, chromotherapy, gemology, hydrotherapy. You name it, India has got it. Uh, Now, I can only speak for the modern medical system, or for the sake of everybody, let's say allopathy. The word homeopathy means I suffer. Allopathy means others suffer. I don't like to use that term at all. Anyway, there are two, but in this, there are two streams. One is the public stream and the private stream. The public stream is the one which is supposedly free, accessible to everybody who needs it. The private system, there are several levels of it, starting from small one-man clinics to mighty corporate hospitals with branches of franchises in every part of the country in all the major cities, and now moving into lesser tier cities. In terms of doctors per million population, I think the recommended um numbers are that there should be. Well, I'm very poor at all this stuff, but we are at about two-thirds the level of number of doctors per population. And when we try to compare the public sector doctors with the and the private sector doctors, when you look at the public sector, which caters to a vast majority of our population, the numbers are very, very small. More, for instance, in Kerala, I understand that there are more private hospital beds than there are public sector beds, public hospital beds. So that speaks for the system. Again, the number of beds are very, very few. I was reading an article a few days ago that in India, the number of beds per thousand population is 0.55 per thousand population, public sector beds. In certain places like Kerala and Bengal, the situation is much better. But when you take the country as a whole, there is the number of beds which are available, the number of ICUs that are available, the number of doctors that are available, the number of ambulances that are available, the number of ICU beds that are available is atrociously low for the need. Even at regular times, forget about corona times, even at regular times, it is woefully short. Now, like I said, I'm very bad at statistics and I have not boned up on the number of beds and the number of beds as recommended by WHO. I'll need to check that out, but I know it's woefully short. Now, as far as ventilators are concerned, again, there are no real figures as to how many ventilators are there in the country and how many are with the public sector and how many are there with the private sector. But we probably have less than 1/10 the number of ventilators which we will require in case this turns out into a full-blown pandemic of COVID in the country with shades of, say, Spain or Italy or United States or even the United Kingdom. So I agree with you that in terms of space, in terms of beds, in terms of equipment, in terms of personnel, in terms of even drugs, maybe we are woefully short, and we have to, buck up. The problem about the lockdown is, as one of my friends was telling me, who's in some ways associated with the pharma industry, is that they are ready to work full time, but the people are not able to reach the factories. The supplies of basic material is not coming. It may surprise people to know that a vast amount of the ingredients necessary for making medications, even in India, used to come from China because the cost factor. It's much more expensive to make the basics here or get it from Italy, which is another big source. So you get it from China. So now that has stopped, and raw materials are not reaching the pharmaceutical factories. So where do they manufacture? Even if they manufacture, they cannot move it out from the factories because there are no trucks, because either the police don't allow the trucks to go or the truck drivers are too frightened to drive. So there is a logistical nightmare out there. And in a country this size and with so much of differences in culture and superstitions and beliefs and fake news and things like that, it has all the ingredients of a catastrophe in the making. So I'm sorry to sound so pessimistic, but this is a fact. And I'm also sorry I cannot give you statistics. Been my very poor. Even if I were to go on today, I'll forget it tomorrow.
No, that's completely fine. But I think that paints a picture for us. If we are not able to control this virus by social distancing or whatever measures we take, our hospitals are just not going to be able to deal with this situation. And another thing I want to talk about is doctors can easily get sick. Now, we already have a very low amount of doctors and nurses are even more prone because they're interacting with the patients more often than the doctors. What can we do here to control that? Because that would make the issue even 100 times worse if we even lower the amount of doctors that we have right now available.
It's an excellent question, Arman. Matter of fact, I was just, somebody had asked me to write an article on medical practitioners, the front line of our fight against COVID. And I recall reading somewhere, I'm not sure where, that Doctors and hospitals are not the front line. They are the last line of defense. The front line are you. I'm a doctor, but at the moment not working. So me, you, everybody else on the street, we have to fight this by social distancing, hand hygiene, following orders, taking some sacrifices in our stride. The doctors are the last defense. If our doctors and the medical system is overwhelmed, who is going to fight this anymore? I agree with you that we are right in the in the face of it as a medical profession, especially the hospitals which have been authorized to admit and treat these patients. See, the simple thing is that our doctors do not have enough PPEs. That is personal protection equipment. Have you seen these fellows walking around in things like space suits? The number of innerwear they have to wear, the number of socks they have to wear, the number of gloves that they have to wear, the innerwear, the outerwear, the zipped up stuff, the goggles, the visors, the multiple masks, the head covers, and all the stuff. We don't have that. We don't have enough. They're working with simple surgical masks. There are many places where they don't even have N95 masks. So it is like 1962 war when our army was asked to advance in adverse weather and face the Chinese with the Lee Enfield 3.303 rifles and face the machine guns of the Chinese. The medical profession is in that sort of a situation. First of all, I told you we do not have the numbers of beds or equipment, and then the doctors and the paramedical staff, which includes everybody from the ambulance driver who brings the patient into the hospital, to the people who receive it, to the security people who control the crowds, to the ward assistants who wheel the patient into the ICU, the emergency nurses, the lab technicians who come in to take the samples of blood and nasopharyngeal swabs, the nurses, the nursing aides, the ward boys, the doctor's assistants. Everybody is at very high risk. So we're trying to set some kind of a pecking order now. I think we are getting enough advice and guidance from our bodies like the Association of Physicians of India, the Indian Council of Medical Research, the Indian Medical Association, that people at high risk stay away from work. Doctors at high risk stay away from work. I'm at high risk at the moment. I'm staying away from work, trying to do some telemedicine and things like that. Whatever I can help, and not trying to endanger myself and my patients. To patients, don't rush to hospitals for the smallest thing. That this has become a style in Kerala now. You go to hospital for the slightest thing. You have a niggle somewhere where it shouldn't niggle. You have an ache somewhere, it doesn't ache. You rush to a hospital. You rush to a doctor because they are so easily available and relatively cheap. So don't do that. Don't go there. You stay at home. Unfortunately, the concept of family physician has almost died out here. Everybody goes to hospital. There's no family physician. I'm a family physician. I have a following. All of them call me before they do anything. So if you have a family physician or you have a relative who's a doctor or you have a friend who's a doctor, call him and say, this is my problem. This is what should I do? And then he would be the one to advise you. Now, if you've got symptoms of COVID, now what are the symptoms of COVID? If you look at the incubation period is the time which takes from the moment that the contagion, the virus enters your body till you show the first symptom of the disease, can range from 1 to 14 days. You can be sick on the second day or you can be sick on the 14th day. So it's a long incubation period. So if you are within that incubation period, and you think you have been exposed or you have traveled from an area which is endemic like Iran or Italy, or now a hotbed is the UAE, and it's causing most of problems in Kerala. Stay at home. Now, if you have a symptom, don't try to hide it. You call your doctor or you call there are enough helplines to call, they will guide you. Now, if they suspect that you've got a thing, only then you go to the hospital. Don't overload the system. So, this is the way we are trying to do it. It's a lot of decisions you have to take for yourself. And many hospitals have closed down the regular OPs. Doctors are working in shifts. Most of the hospitals here have now divided their workforce into two. 50% of them work for 7 to 14 days, and then they stay at home for the next 7 to 14 days. 50% of them do the other way, do it for the next 7 to 14 days.
Mm-hmm.
So the advice would be that, if you've got a fever with a sore throat and a bad breathing difficulty and a cough, don't sit at home saying, Dr. Sujit Vasudevan said, don't go to the doctor. I think is that you have to be the guide. Contact your doctor over the telephone first and say, these are my symptoms. This is what I've done. I've been moving around. I was in Dubai 2 weeks ago. What do you think I should do? And then follow that advice. That will definitely reduce the strain on the hospitals. It'll reduce the strain on the short resources which are available. And that is the best advice I can give. The distaff, of course, is that now if you have got a little bit of a chest pain and then you decide, okay, doctors have said that it's okay, and that turns out to be a heart attack. Now, where does that leave us? So I think
that's a great point to go into a little bit here. Because of COVID, we're going to see a lot of fatalities from other medical related things. Like, for example, if someone's having a heart attack, like you just said, if someone has cancer, the attention given to them is going to be much lower.
Can I stop you there? I think we have to separate out these two things with a very, very wide gauge between cancer and cancer is one section in most hospitals which is treated, which is not being shut down.
Okay.
Despite COVID, cancer centers, to their credit, are working. Chemotherapy is being given, radiotherapy is being given. While most elective surgeries are being deferred, cancer surgery is going on in most hospitals, to my knowledge, which is very limited to Cochin. This is what I've been calling up hospitals and asking them and talking to my cancer patients and asking whether they are being regularly followed up. And they say yes. The hospitals even send ambulances for them to go in for their chemotherapy. So we have to, I don't think we are going to lose cancer patients to COVID. We are going to lose cancer patients to cancer. But the other side is true that if we drill this into the heads of our people that, you should ignore symptoms, then maybe we are going to lose patients to non-COVID diseases. But that is where what I tried to explain right at the beginning, that when you have a symptom, you must have access to a doctor with whom you can discuss the symptom. Now, if one of my patients calls me and tells me that I've got a chest pain, and I'm sure that he has not traveled anywhere for the last 14 days and he's not had exposure to COVID, I will ask him to come to my clinic. I have no staff, but I will take an ECG myself and I will interpret it, and I'll find out whether that he's got any chance of a heart disease. ICUs are still open in all hospitals. They are not closed them. So I think this is where the patient and the doctor both have to be on the same page and, use common sense and judgment for treatment. I am only saying that if you start sneezing, you wake up today morning and you start sneezing because you've always been going to an air-conditioned office, but today your wife asked you to dust the furniture and you start sneezing, you don't rush to your doctor thinking that, could this be the first sign of corona?
Correct.
You see the difference between the two things which I'm saying. So, a lot of it has to be left to individuals' discretion and judgment and common sense.
Right. And I think, again, that leads to another good point that we should talk about. And it will lead us into a few good case studies of people and countries who have dealt with it well. But can you go into the importance of testing of COVID-19? Why is it such an important factor that we should be looking at, and how will it help us? And then we can go a little bit into, how South Korea used testing to really control and maintain the number of cases.
Right. Right. I think the WHO, one of the very few good things that it has done, one of the good things that they have done is that test, 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 and test. By testing, one is you are able to um, exclude a lot of patients who you thought could be having COVID. You could also diagnose early. Now, unfortunately, the ICMR's initial guidelines, which I feel were uh, due to shortages of testing kits. Nobody is really prepared for these pandemics, and
Mm-hmm.
every country, we do not. We only recently started making these kits. We were importing them at something like 4,500 rupees a test, which is what has been now allowed by the private labs to charge. So we did not have enough kits, and we were our testing rates were some of the lowest in the world. If I remember, at one point in time, I remember seeing a kind of chart which said that we were testing 6.8 persons per million population when South Korea was doing close to 5,000 per million population. I mean, where
Correct.
is 6.8 and where is 5,000? I think last week the numbers have gone up a little beyond 10. I vaguely remember seeing it somewhere. I can't put my hand on my heart and say
Sure.
I've read that somewhere. But the reason, so ICMR's initial thing was that you test patients with symptoms only. Okay, so if you have traveled from Iran and within the next 14 days of having traveled to Iran, you come with a sore throat and a fever and a lower respiratory symptom, you are eligible to undergo the test, which is what they do is a nasopharyngeal swab. They do a, a long broom with a thing is put through the nose to the back of the throat, another one is put through the mouth to the back of the throat, and you take swabs, not at the same time, at different times, and that is transported through a virus transporting medium to a lab, and the report takes between 24 and 48 hours. The test is called as a RT-PCR. The full form is reverse transcriptase polymerase chain reaction test for the virus. So only those people who were suspected to have traveled to a infested place or been exposed to somebody and who had symptoms were eligible to be tested. And whereas you mentioned South Korea specifically, I think Taiwan also did that. They set up a mass testing center because if you recall, in South Korea, that a number of people had gone to a church. There was one church group where a whole number of
Correct.
people became symptomatic. They tested all of them, and everybody would come in contact with them. Anybody could get a test. They had even like they have McDonald's drive-through. They had drive-through testing. You could go in your car and get. They started in Malaysia also. They could, but Malaysia is charging. South Korea, I understand it was free. I'm subject to correction. That they would test, so they could test a whole lot of people and reassure them that they did not have the COVID virus, the coronavirus, with the result that it not only settled a lot of anxieties, but then they never had lockdown, they never had a run on their medical systems, they did not even shut down the international airports. Um, on the other hand, when you look at places like Italy or Spain, they tended to disregard this social distancing. It was only when it was a little too late that they got into social distancing and they started, even they were very sluggish with tests at the beginning, extremely sluggish with the testing. We have got now rapid tests which are coming in. There's even a Indian-made rapid test by a company in Pune, where you've been able to get the test in something like 2.5 to 3 hours. And I think they are getting it from Abbott and places like that, where they are able to do a similar sort of test, PCR, polymerase chain reaction test. They're able to do that and give you the result in 2.5 to 3 hours. And they're able to bring down the cost from 4,500 rupees to much lower
Mm-hmm.
levels of maybe 1,500 rupees or so. So with that and the import of larger number of test kits, I think our testing numbers should go up. Uh, it will probably help us to detect cases, isolate them, quarantine them at earlier stages, and probably prevent the spread of these things. I would also like to, if there is any influential person, the decision maker, listening to your broadcast, a podcast, is that we must think of having compulsory quarantine centers where people who are strongly suspected of having this should be forcibly kept away from the rest of the population. See that they are well fed, that they are comfortable, that they are hygienically looked after, that they get their basic needs, but they should be kept away. I think we made that two or three small mistakes which could have very big consequences, is keeping our airports open so long for international travel, not
Mm-hmm.
detaining these people who had come from this so-called thermal scanning. It's such a ridiculous thing because thermal scanning tests your temperature. Now you don't get a
Correct.
temperature, you don't get a fever till you become symptomatic, and it takes 14 days
Mm-hmm.
sometimes for you to become symptomatic. What is the use of measuring the temperature and telling them you've got no fever, you can go home? There have been cases in Kerala of people who have gone repeatedly to public sector hospitals saying, I have come from Dubai, can I be tested? And they've been told, you're not symptomatic, you go back. A person apparently came in an ambulance or was sent back by an auto rickshaw, 3 days later tested positive. It
Mm.
talks of certain irresponsible attitudes and trying to, follow the law to a T, which said that you do not test asymptomatic patients. I think if if we had tested, even now, if we start testing asymptomatic patients whom we suspect, test every patient in every hospital who has been admitted for a respiratory problem. Only then we are going to know whether there's a community spread. At the
Correct.
moment, we are shouting from the rooftops that there is no community spread. But do we really know
Correct.
whether there's a community spread or not? How are we going to know that?
Mm-hmm.
All the
And I
cases that
think
we are seeing so far. Pardon? Sorry.
I was going to say I think that's a huge point that South Korea did as well. They tested a lot of asymptomatic people. So
Right. They
whether they
did.
had the
They did.
disease or whether they had symptoms or not, they were testing and then using that and a combination of data such as, they were doing amazing things like using credit card data to
Right.
analyze
Telephone
where
data,
people
mobile
have
data.
been.
They were tracking you on
Exactly.
mobile. They were tracking you on the mobile. Yeah, that's right. That's right.
To see if
They
you
did
have
that.
come in contact with people, and those people who you have come in contact are then given a notification, hey, look, you've come in contact with someone who has the virus, you should probably self-isolate. These measures are super important to get on top of
Yeah,
the
yeah. I
virus,
mean,
and like you said.
that advice is going out in India. There's no doubt that advice is going out here through every medium. But the testing is not being done, which is sad. I mean,
Correct.
but then we are not a sorry, we are not a very rich country like South Korea. Um, you know, we can't, and we didn't have the test kits. So I suppose there are excuses. These are excuses. We can't say that that 6 months ago we should have placed an order for 12 million kits of reverse transcripted polymerase chain reaction kits for
Mm-hmm.
testing an unknown uh, virus which is being seen for the first time ever in the history of the world. So,
Correct.
but then
Correct.
the
That's
same. I
that's
mean,
very
this
true. We
applies. This
can't.
applies to the UK. This applies to Spain. It applies to the United States. It applies to Portugal. It applies to Italy. Italy,
Mm-hmm.
Italy has reached such a stage that again, I don't know whether this is true, but it could be quite true that they do not treat people beyond a particular age. If they say that they are sick, they said,
Prioritization.
no,
Correct.
not going to waste our resources on these people. We'll try to save the younger, more productive people who are worth saving. So
Mm-hmm.
this is called as triaging. It's called triaging. That
Mm-hmm.
it happens during mass casualties or during a war when the helicopters or ambulances bring in people who have been struck by a mortar shell or a a 55 millimeter, 155 millimeter howitzer shell. And they look at all these fellows. Okay, this guy has got part of his head blown off. Put him aside. This guy's got
Mm.
both his lower limbs shot off below the hip. Put him aside. This guy has got shrapnel in his abdomen. Take him for surgery. This guy. So you sort of do triaging. You sort of take a decision on the ground. Who is going to get treatment? Who is not going to? The person who's got the best chance of survival, treat him. So that kind of
Mm.
triaging is occurring in Italy, at least. I'm sure that if we do not follow all the guidelines and don't do all the things that we have been talking about, that doctors in India are also going to be put in the same position of being asked to triage their patients, because
Right. And
there
I
is
think
only so much of the pie to go around. No, you can't feed 10 people with 2 idlis.
that's very true. And I think that that'll be a very, sad consequence if we are not
It's a
able to
sad
contain this
consequence, but
disease.
this is Alma, this is war. This
Mm-hmm.
is war. You cannot, it cannot be a cushy affair. It
Mm-hmm.
is reality. It is reality. It is a shortage of everything except patience.
Yeah. 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 And I think,
I hope that I don't sound very cruel or distance myself from emotion totally when I say these things. I don't.
no, I think
I
it's
am.
it's an important thing to bring up because it is an eventuality if the series of events continues the way it is. And it's definitely something that we have to think about. And it's a philosophical debate almost that our leaders of the country will have
we
to
are, we
take
are, we are
up.
we are days above, I mean, from being a philosophical debate to becoming a reality debate.
Correct.
Not we are not even weeks, we are days away from it.
Mm-hmm.
Next two
Mm-hmm.
weeks will be extremely decisive for India.
Mm-hmm.
If
Agreed.
yeah, so if we can sort out some of the insurmountable problems that we have, like these migrants, which is it's sort of uh, I'm not prone to cry, but when I look at this TV, I get tears in my eyes. When I look at the people suffering like this.
Mm-hmm.
And there's
I
nothing
agree.
that anybody can do or could have done to prevent this from happening, unless you had, enough time to react. Everybody says you
Mm.
shouldn't have done this, you shouldn't have done the lockdown. Then what is the effect of that? Nobody thinks of that.
Correct. And I think let's move into a little bit of the closing because we touched on
Yes.
a few
Oh,
very
I'm so
good points.
sorry.
So
I told you you must stop me when I yeah.
no problem. So we touched on what is the virus and how do we contract it, the theories behind the way it started, the overburdening in Indian hospitals potentially, and the existing overburden, and the importance of testing in South Korea's case study. But let's end on a little bit of a positive note for everybody, because there are a few potential long-term. It may be hard to see right now, but there are a few potential long-term benefits that we can get out of this. One being
Yeah.
there may be a prioritization towards healthcare in the future in terms of investment. So we will be more prepared and more ready for handling everyday and day-to-day diseases and viruses in our country. And also, if you do have knowledge on this, could you expand on India has experience in dealing with previous viruses. Polio, we were a big part in, we did
True.
a great
True.
job in eradicating polio. So I
Yeah,
think,
I'm very proud that I'm a Rotarian, and Rotary has contributed so much to polio, so much to polio. Unfortunately, its role has not been really defined by the government, but our role, we have been fighting polio for more than 25 years now. I have been fighting polio for 25 years now, anyway. So yeah, tell me. Yeah, sorry.
so could you expand on that? Like, how did we just briefly, how did we fight that, and how can we use some of that
See,
expertise
it
to
is we
potentially
fought
fight
we fought
this?
smallpox. We fought smallpox and polio. The
Correct.
WHO has given us credit that we were in the front line again. Like, use the word front line, like it's going out of style. Um, but then smallpox has been endemic in India. It was never an epidemic in the sense that it never it used to spring up here and there, but then it has smoldering cases all the time, all over the place. So we did that. We treated both these diseases with a very well funded, very well thought out, and extremely well carried out vaccination program. Okay, you the way to eradicate a disease, there are two things that you do. One is you treat a disease, and the second thing is you eradicate a disease. The only smallpox and polio you find in 4 countries in the world, with the fifth country unfortunately reporting cases a few months ago, wild polio cases. But smallpox is found only in labs, unfortunately, mostly in military labs, where it's been kept as a potential bioterrorism weapon. But you if you vaccinate 100% of the population against a particular disease over a period of time, the disease will disappear because it gets into you. Oh hell, there is I got antibodies against me. It comes to me. The antibodies here ultimately doesn't survive. It has got no host. It cannot get into a cell, so it sort of dies out. So it starts dying out in small communities, larger communities, and then that's how it worked. And we are now doing what are called as the mopping up operations for polio, in that twice 2 days in a year we still give polio virus, even though polio vaccine is universal now. Polio vaccine is given to all children. Everybody understands that all children have to be vaccinated against polio. We are still using the oral polio vaccine. In the US, they use the injectable polio vaccine. But all children are vaccinated. But we are just mopping up operations in case somebody was sick the day and did not miss it, or the parents were sick or were out of town and missed the dose. So we give the children the benefit. This is how we beat polio, how we beat smallpox, and how we beat polio, by vaccination. Unfortunately, there is no vaccine for this drug for this disease as of now. But in Seattle, in United States, in Washington State, in the United States, they have started off with vaccines. The UK is working on vaccines. India is working on vaccines. But the problem about vaccines is that it takes a long time to develop these vaccines. They have to be tested on human volunteers for possible side effects. Therefore, for the safety reasons, they have to be tried on patients, and then they have to be mass manufactured. All this takes time. So we are probably 8 to 12 months from the nearest vaccine. So that is probably the only time that we will be able to really try and fight the disease. And maybe that will save the people who are left behind. We don't know how many are going to be left behind when this pandemic is over. Scary thought, but we have to think of that too. So I think vaccination is going to be the ultimate answer. Till then, prevention. There is no cure. They've tried a whole lot of this thing. Most patients, 80%. The good thing is that 80% of people recover without medications. They recover on their own, just like the flu. You get this like the flu, you recover like the flu. See, many symptoms are similar to the flu. 20% of patients who require hospitalization, who require critical care, who require intensive care, they have tried chloroquine, they have tried dihydrochloroquine, they have tried drugs, antiviral drugs which were formerly used for HIV, like lopinavir and ritonavir. They have tried a failed drug for which they tried for Ebola, which is called as remdesivir, which is found to be effective. They have tried some interferon beta, which are antivirals. So those medicines are being used for treatment, but there is no guidelines. There is a study which has been recommended by WHO called as the Solidarity Trial. About 50 molecules are being tried in various parts of the world. India also is, I think, part of the Solidarity Trial, because we have also got adequate patients now to try these on. 4 drugs are being tried to see, and then there may be recommendations. So maybe we can win over this, but at the moment, the virus seems to be winning.
Sure. Yeah. That makes sense. And vaccinations are very important. Like you said, I listened to an interview with Bill Gates on a TED Talk, and he said we're about 18 months away potentially from a vaccination. So yeah, until then we will have to use containment strategies. But
Yes.
I would like to again end on the positive note that we will
the
redirect
positive
more
note. Let me
funds.
tell you, Armand, the very positive. Could I just interrupt you for a minute to tell about a very positive note?
Yeah, please.
Air I breathe in today is very healthy,
Correct.
much more cleaner than what we do. The skies are brighter, bluer, and birds are coming to my garden. I saw 2 red-vented bulbuls yesterday. I saw 2 Lawton's sunbirds day before yesterday. Whole lot of munias. I think that's the plus side of this. Maybe we'll realize that we need to give a little bit back to nature than to take everything out of it. Now you finish.
I agree.
Yeah, sorry.
I think it may be a cool thing we even think about in the future. Giving a week where we all work from home and we all do. We close down everything and reduce the strain that we're putting on the environment, because it will have huge consequences. But Dr. Sujit, thank you so much for your time. I think this is a good place to close up. We've covered a lot, and thank you so much for your time.
You're welcome. I hope something helps. Yeah.
It definitely helped. And thanks everybody for listening. See you on the next podcast.